photocopied, or in any way reproduced, shared, or lent to any person or disposed in any manner. Any handouts or review materials found in the possession of another person whose name does not appear therein shall be prima facie evidence of violation of RA 8293. Top-notch review materials are updated every 6 months based on current trends and feedback. Please buy all recommended review books and other materials.
What is the most common congenital cyanotic heart disease? Okay, so this is a very easy question. You have to know the answer. So when we're talking about congenital heart diseases in children, one easy way to categorize them is if it is cyanotic or acyanotic. So if it is acyanotic, then your shunting is, ano yun? It's left to right. If it's cyanotic, it's right to left. Okay, and overall, the most common congenital heart disease is your VSD, be it cyanotic or acyanotic. Okay, but for cyanotic heart disease, the most common would be your tetralogy of Fallot. So you have to be able to know the details, the nitty-gritty details of your TOF, your tetralogy of Fallot, and that is what we are going to discuss in the next few slides. Okay, so again, this flowchart, this diagram shows you how to categorize your cyanotic and acyanotic heart disease, left to right and right to left shunt. So please do remember VSD, ASD, PDA, coarctation, endocardial cushion defect, all of these are acyanotic heart disease. But mind you, if this disease progresses, tapos nag-heart failure in patient, and for example, VSD, there's what you call your Einstein-Mengerization syndrome, parang ganun, Einstein-Mengerization, okay, then pwede rin sila maging cyanotic in the long run. Okay, the same is true with PDA. If you have a very large PDA, tapos mataas yung pulmonary pressure, meron kang pulmonary hypertension, then the flow can reverse and pwede siya maging cyanotic. Okay, but in general, these shunts will cause acyanotic heart disease. Okay, for cyanotic heart disease, we all know that these patients present with cyanosis. There's a mixing of your oxygenated and unoxygenated blood, and there's some level of hypoxia. So when you check their SpO2 using a pulse oximeter, there's some degree of hypoxia or hypoxemia. Okay, when you check the blood gas. So that's why it's very important. There have been guidelines, there have been journals that recommend testing the pulse oximeter reading of newborns, okay, in all 4 extremities, because this is one easy way to rule out your cyanotic heart diseases. Okay, so if you get a reading less than 92% in any extremity, then you might want to rule out your cyanotic heart disease or other congenital heart diseases. Okay, so we all know this. Okay, but please also do note, okay, that another way to classify your congenital cyanotic heart disease would be to look at your pulmonary blood flow, okay? Because they can be subdivided further into those diseases with decreased pulmonary blood flow and increased pulmonary blood flow, okay? Those with decreased pulmonary blood flow, these are the lesions with RVOT, your right ventricular outflow tract obstruction, RVOT obstruction, meaning the blood going from the right ventricle, there is some form of obstruction preventing blood flow going to the lungs, and that is why you have decreased pulmonary blood flow. And how does this manifest clinically? When you look at the x-ray of these patients, yung lungs nila maitim, decrease yung blood flow, versus this one, may increased pulmonary blood flow. When you look at the x-ray, mas congested yung itsura ng x-ray nila dahil wala kang obstruction going out of your right ventricle. Okay, I hope it's clear. So for those with decreased pulmonary blood flow, this is pulmonary atresia, pulmonary stenosis, TOF, dahil meron siyang pulmonary stenosis din, tricuspid atresia and Epstein anomaly. And for those with increased blood flow, that's your TOGA, okay, transposition of great arteries, TAPVR, and truncus arteriosus. Okay, so I hope this is clear. Okay, so very easy way to categorize your congenital heart disease. Okay, para kapag naghahanap kayo ng differential diagnosis nyo for a child presenting with congenital heart disease, you can use this flowchart. So tingnan nyo muna cyanotic ba siya or acyanotic. If it's cyanotic, tingnan nyo yung blood flow sa lungs. Meron ba siyang RVOT obstruction or wala? Ano yung x-ray niya, congested or hindi? Okay, so that's how you look at it. Okay, so let's go to TOF. Again, very important ang TOF. Okay, so let's discuss TOF in detail. Please remember the main lesions of your TOF. The mnemonics, there's prove, you have to prove PROV, okay, you have to prove that your patient has tetralogy of Fallot. So pulmonary stenosis, okay, your right ventricular hypertrophy, overriding aorta, okay, and your VSD. Okay, so meron kang VSD and yung aorta nag-override dun sa VSD, kaya yung outflow from the right ventricle, your cyanotic blood, okay, napupunta siya dun sa systemic circulation nyo. Okay, so when we discuss tetralogy of Fallot, we also have to discuss your TET spell. So basically what happens in TET spell is, for whatever reason, okay, your blood flow going through the lungs is further decreased, which causes your unoxygenated blood to be shunted more towards your systemic circulation, thereby worsening the degree of your cyanosis. So this is a vicious cycle. So what triggers TET spell? There's a lot of theories which triggers it, okay? But mainly, a lot of studies will agree that it's because of your catecholamine release. And when does this happen? Usually pag yung bata yan, irritable, umiiyak, kunwari, napagod sila, or for example, tumae sila, or tinusok sila ng bakuna, okay? But aside from that, there are other triggers such as yan. It's very common in the warm morning, sabi dyan, when the systemic vascular resistance is low. So mamaya, i-discuss natin, meron tayong maganda illustration dyan, what triggers your TET spell. Pero for now, what I want you to know is yun nga, what happens is, bumabagsak yung blood flow papunta sa lungs, meron ka ng obstruction dito to begin with, tama yan, di ba? Pero during the episodes of TET spell, lalo pang nag-worsen yung obstruction na yan. So hindi mo ma-oxygenate yung blood mo, tapos yung unoxygenated blood mo, lalo siyang pupunta sa systemic circulation. So again, babalikan natin yung illustration na mamaya. Okay? So it's a paroxysmal attack, paroxysm of hyperpnea, so hypnea, irritability, prolonged crying, increase in cyanosis, and sometimes there's decrease in intensity of the murmur. Okay? So precipitated by crying, defecation, or other activities that causes catecholamine release. Okay? And it is usually initiated by events that lowers your systemic vascular resistance. Okay? Bakit importante yan? Again, later sa next slide. Okay? To manage it, you usually put the child in a knee chest position and you give morphine sulfate. So again, sasabihin din natin mamaya kung bakit yan yung management. Okay? So again, to summarize your TET spell, it is triggered by catecholamine release. Okay? And your management goal is to increase the blood flow going through the lungs. So gusto mong mas maraming blood ang makakalusot dun sa yung pulmonary stenosis papunta sa lungs. Okay? So ito yung sinasabi ko sa inyo, one of my favorite illustrations to understand your TET spell and what's happening. Let's start here. Okay? So these are the theories, okay, that causes or initiates this TET spell. So yung spasm of your right ventricular outflow tract, question mark yan. May mga studies na nagsasabi na pwedeng trigger. Yung ibang studies sabi nila, hindi yan yung mechanism. Pero nandiyan pa rin siya, question mark. Increase in systemic venous return. Okay, wag malilito ha guys. Traditionally yung SVR, pag sinabing SVR, systemic vascular resistance yan. Pero for this cycle, nakasulat dyan, increase in systemic venous return. Meaning, mas maraming blood na bumabalik sa right side ng heart, systemic venous return, na unoxygenated blood. Okay? So marami kang unoxygenated blood, kaya lang, hindi ka makalusot dito sa pulmonary stenosis mo. So saan pupunta yung oxygenated blood? Magsashunt siya. Okay? Or crying, or other activities, dagdag nyo dito, catecholamine release. Okay? And yun, para hindi kayo malito, isulat nyo sa handout niyan, increase in systemic venous return. Okay? Pero actually, ang mas nagtitrigger talaga ng TET spell is your decrease in systemic vascular resistance. Okay? So again, Yung systemic venous return, ito siya, sa side ng heart na to, sa right side. Yung systemic vascular resistance, isipin nyo siya yung resistance ng blood palabas ng aorta. Kaya nga siya systemic vascular resistance. So, kapag bumagsak yung systemic vascular resistance mo, ibig sabihin, free flowing itong number 3, yung blood palabas sa aorta. Pag wala kang resistance dyan, what happens? Di lahat ng unoxygenated blood mo, magsashunt papunta sa aorta. Does it make sense? Okay? May harang ka dito, wala kang harang dito dahil bumaba yung systemic vascular resistance mo. So, ito, maluwag, ito, masikip. Saan pupunta yung blood? Pupunta siya sa number 3. So, nagkakaroon ka ng cyanosis. And what happens if there's cyanosis? Pupunta tayo ngayon dito sa cycle na to. Okay? Kaya lang, please do the corrections. It's supposed to be decreased oxygen because of the cyanosis, increase in carbon dioxide, okay, and decrease in pH. So, it's hypoxia, hypercapnia, and acidosis. Okay? So, yan yung magiging effect kapag na-trigger yung TET spell. Diba? Hypoxia, hypercapnia, eventually acidosis, metabolic or respiratory acidosis. Okay? And then what happens? Your body tries to compensate by increasing the respiratory rate. Your body tries to blow off your carbon dioxide and increase the oxygen by making your child more takipnic. The problem is, kapag naging takipnic yung bata, mas tumataas yung venous return. So, balik tayo sa cycle na magkakaroon ng increase ng left to right shunt. Okay? Does it make sense? Clear so far? Okay? So, how do you manage your TET spell? You manage your TET spell by countering these mechanisms. So, you give your oxygen to address the hypoxia. You give your morphine to sedate the patient and hopefully decrease your respiratory rate. You give your bicarbonate and fluid hydration to address your acidosis. Okay? Does it make sense? Okay? So, ito yung sinasabi ko na if you know what's going on, if you know the pathophysiology, then you will know the management. Okay? You put the child into knee chest position. Dahil pag knee chest position mo siya, what happens? Okay? It increases your systemic vascular resistance. So, pag mataas yung systemic vascular resistance mo, yung blood mo hindi siya basta-basta makakalabas dito sa aorta. Hindi siya basta-basta makakapunta dito sa number 3 kasi nga may harang, may resistance dito. And what happens? Basically, you're giving the heart more time to try to force the blood to go to the lungs. Okay? So again, nagets nyo? That's how you manage it. Knee chest position, give oxygen, bicarbonate, hydrate, okay? And then you give your morphine, you sedate. Okay? So is that clear? Okay? So some confusing matters. So does knee chest position increase or decrease your systemic vascular resistance? Kasi usually natatanong yan eh. So the quick answer is it increases your systemic vascular resistance. Okay? So kapag inipit mo yung mga great vessels mo, pag nag-knee chest ka, it increases your systemic vascular resistance. Okay? Ito yung mas nakakalito. Does the knee chest position increase or decrease your venous return? Okay? Ang sagot is it depends. Okay? Isipin nyo, pag nag-knee chest ka, di ba? Isipin mo may hose ka. Pag pinindot mo yung hose, anong mangyayari? Initially, dadami yung blood flow. Okay? So, balik tayo sa illustration na. So, ito yan. Dito yung systemic venous return. Pag nag-knee chest ka, initially dadami yan. Tataas yan. Okay? But, eventually, dahil ipit na yung mga vessels mo, yung blood going back to the heart, babagal din siya. Magdi-decrease siya. Tama? And technically, we want that. Kasi, sabi nga dito, increase in the venous return might exacerbate your TET spell. Kasi nga, ang dami mong unoxygenated blood, wala naman siyang time pumunta sa lungs. Whereas, pag inipit mo yan, mas babagal yung flow dito, mas makakapunta siya dun sa lungs. Okay? Then again, sabi ko nga sa inyo, bakit may confusion? Unang-una, nalilito yung mga tao dun sa SVR. Guys, for the board exam and what is taught to you in med school, it's better to stick to the knowledge na yung SVR is traditionally and more commonly it's systemic vascular resistance. It's not the venous return. Okay? And when they ask you if knee chest increases or decreases your venous return, the safer answer for the board is that it increases it. Okay? And this is what you will find. Okay? What you will find in most textbooks. So, increase in the volume, meaning increasing the volume going back to the heart. Okay? So you give your fluids, you give your knee chest to increase your venous return, or you transfuse if the patient is needing of blood transfusion. Okay? All of the premise ng management na to increase the volume is to increase the preload, para mas gumanda yung circulation ng heart. Okay? But there's a journal that's very hard to contest. Again, this is a resident level discussion, pero I would just like to say, there's a journal which measured the blood flow on the right side of the heart, okay? And the measurement showed that pag naka-knee chest sila, the venous return actually decreases. So that's very hard to contest, okay? Pero again, for the exam, because this is what's written in the textbook and it's more common knowledge, if they ask you straightforward, what happens when you do your knee chest, does it increase your venous return? The answer is yes. Okay? It increases your venous return initially. Okay? So, do you want an increase in venous return? Doc, sabi nyo pag madaming venous return, mas lalong lalala yung TET spell. Okay? Bakit natin tinataas yung venous return? Again, we want to increase the circulation of blood. We want to increase preload. Ang premise nito is, we're increasing preload, but we have to make sure that that preload is able to go to the lungs. And that's why you have to address the other factors simultaneously. Okay? Kasi kung tinaasan mo yung venous return mo, pero wala kang mababa yung vascular resistance mo, delikado yun. Pero kung tinaasan mo yung venous return mo, pero mataas din yung systemic vascular resistance mo, naka-knee chest position na siya, okay lang yun. Kasi saan siya pupunta ngayon? Pipilitin mo siyang pumunta sa lungs. Okay? Does it make sense? I'm sure it might be a little bit confusing, so just please replay this discussion para mas maintindihan nyo siya. Okay? So, there's a very good mnemonics there for the management of TET spell. It's NACE, so positionate. Okay? Positionate. That's your knee chest position. Oxygenate to prevent hypoxia. Sedate to decrease your hyperpnea. Bicarbonate to target your acidosis. Okay? And other managements would be to give your phenylephrine. You can also give your beta blockers. Okay? Tama ba? Beta blockers, tama ba? Bicarbonate, morphine, phenylephrine. Yeah, beta blockers to address your infundibular spasm. Okay? So, yeah. Alright, so hopefully we understand the etiology of a low and your TET spell. Lucy is a 2-year-old who was brought in for consult due to chronic cough. Okay, on and off cough lasting for more than a week since 4 months ago. So, apat na buwan na siya nag-uusip ko na medyo mga 1 week daw tumatagal. There are different consults with multiple courses of antibiotics. However, the cough seems not to go away. Okay, so hindi siya nawawala, chronic. So, ang dami yung pwedeng differentials, diba? Asthma could be a differential, foreign body, although usually hindi naman chronic yun, pero pwede. Okay, episode is usually associated with fever and loss of appetite. So, this is very important. So, usually you don't associate asthma with fever. Okay, loss of appetite, medyo mag-isip ka rin ng ibang sakit. Okay, and then there's weight loss. Okay, immunization is complete. Okay, X-ray findings are suggestive of TB. So, nagpa-X-ray sila, sabi suggestive of TB. So, minsan binabasin primary cox infection. Okay, and then you did your PPD, your measurement is 7 millimeter. Okay, so is this positive? Okay, so you have to know the cutoff for your PPD, your tuberculin skin test. Okay, your 5-TU test. Okay, so how will you treat this patient? Okay, so the answer would be, should you give INH prophylaxis only? Should you do further workup? Are you not yet convinced of your diagnosis? Or should you start your patient already on anticox treatment? So after reading this case, you have to be thinking of TB already. The only question is if this is infection, exposure, or TB disease, di ba? Yun na lang dapat yung pinag-isipan niyo. So you shouldn't answer IV ceftriaxone, okay? Unless meron kang coincidental or meron ka rin finding na pneumonia on X-ray, then yes, pwede. Pero for this case, if you encounter this question in the board exam, dapat ang pinagpipilian mo lang dyan is B, C, or D, okay? The answer is you should give your full course anticox treatment. Okay? So please remember, we classify TB infection in children in the following. It could either be exposure, infection, or disease. Okay? Pag exposure ka lang. So tingnan nyo to, yung may mga positive. Infection, ibig sabihin na-expose ka, pumasok sa katawan, nagkaroon ka ng infection pero na-control siya ng immune system mo, so hanggang dun lang, hanggang infection lang, hindi ka nagkasakit. Okay? Well, nagkasakit ka pero hindi ka nagkaroon ng symptoms, hindi ka nag-manifest. So na-control siya ng katawan mo. And how do you differentiate exposure from infection? That's your PPD positive. Okay? If you had exposure, you had infection, and then hindi na-control ng immune system mo, dumami yung TB bacilli sa loob ng katawan mo, nagkaroon ka ng symptoms and findings, sabi dyan plus or minus X-ray, plus or minus symptoms, then you can classify it as a disease. But mind you, before you classify your TB as a disease, as TB disease, meron pa yung criteria, which we will discuss later. First, we go to your PPD. Paano mo malalaman kung positive ang PPD? The cutoff for PPD is actually 10 mm. Please remember that, it's 10 mm. But 5 is considered positive if any of the following is present. You have a close contact, okay? And here in the Philippines, halos lahat tayo may contact sa mga cases na may TB, di ba? Sobrang daming TB sa Pilipinas. Or you have clinical findings suggestive of TB. Again, may criteria pa yan. X-ray findings suggestive of TB, or if you have an immunocompromised situation. In which case, if you fulfill any of these, 5 mm is already positive. So for your patient, kanina dun sa case na yun, 7 mm, is it positive? Yes. May symptoms siya. Wala ng 4 na buwan, naubo niya. May X-ray finding siya. Okay? Probably may exposure siya. So it's PPD positive, 7 mm. Okay? So when we're talking about your tuberculin skin test, okay, when should you do it? So hindi lahat ng patient ay kailangan ng tuberculin skin test. Okay? So this table is found in your Manual of Procedures for the National Tuberculosis Control Program. Please do read this, very important. This is 190 pages of critical information for managing tuberculosis. Okay? Doc, sobrang dami, 192 pages. Of course, hindi naman kailangan memorize lahat yun. Hopefully, in the next few slides that we'll be discussing, sana ma-summarize ko yung mga pinaka-important and sana maalala nyo. Okay? So, for example, like this table, this is very important. Okay? Ang tanong dito is, do you have to do your TST, your tuberculin skin test, before starting your TB prophylactic therapy, your TPT? Okay? Or your IPT, isoniazid prophylactic therapy. Before we call it IPT, isoniazid prophylaxis therapy. Ngayon kasi may ibang regimens na meron ng isoniazid plus rifampin for 3 months, so pwede na yun, versus the traditional isoniazid for 6 months. Okay? So, this table summarizes whether you need to do skin test prior to initiation of your your TB prophylactic therapy. Okay? And as you will see, the 5 here is very important because less than 5 years old, studies have shown that they are more prone to developing complications of tuberculosis. And as such, these patients, ang approach natin mas aggressive. Okay? Mas aggressive, mas maaga ka nagtitreat. And this is what you will see in this specific table. So let's dive into it, okay? Let's check the nitty-gritty details again. So sabi dito, household contact. Kasama mo siya sa bahay, nakatira sa bahay, okay? If your patient is less than 5-year-old and it is bacteriologically confirmed exposure, ibig sabihin yung tatay, bacteriologically confirmed na may TB siya, TB culture, AFB stain, gene expert, you don't have to go to your tuberculin skin test, mag-treat ka na agad ng prophylactic therapy, okay? Again, the premise is your patient is not TB symptomatic or he doesn't fall or he doesn't fulfill your TB disease, okay? Dapat hindi siya disease. Otherwise, if disease siya, full treatment regimen lang. Pero if hindi siya disease, na-expose siya kay daddy, tapos less than 5 years old, bacteriologically confirmed si daddy, huwag ka na mag-skin test, treat na agad. Okay? If it's more than 5 years old, more than or equal to, bacteriologically confirmed, pero meron siyang TB risk factors. Ano ba yung mga TB risk factors? Living with HIV, diabetes, so forth and so on. Treat ka na rin kahit more than 5 pa yan. Okay? If less than 5, pero clinically diagnosed lang yung index case, wala kang bacteriological evidence, clinical lang, then mag-skin test ka muna. If positive, you treat. If more than 5, okay, bacteriologically confirmed, pero walang TB risk factor, skin test ka muna. Okay? These patients are not eligible for prophylactic therapy. So more than 5, tapos clinically diagnosed lang. Okay, clinically diagnosed, hindi siya bacteriologically confirmed, negative yung mga bacteriological test niya, then you don't have to give prophylaxis. What about for close contacts? Close contact, all ages, pag bacteriologically confirmed, TST ka. All ages, if clinically diagnosed lang, hindi kailangan. Okay, and then you have a separate guidelines for those with HIV. Okay, HIV, pag more than 1-year-old, automatic pag may HIV yan, prophylactic therapy ka. Okay, less than 1-year-old, if not contact of a person with TB, hindi mo kailangan prophylaxis. So hope this is clear. Okay. Now, let's go to TB disease. So, sabi ko sa inyo, so na-discuss na natin yung exposure, yung infection, na-discuss na natin yung pag-check kung positive ba yung PPD reading niya, na-discuss na natin yung prophylactic therapy, when to do your skin test bago ka mag-prophylaxis. Now, disease tayo. How do you say that your patient has TB disease? You have to fulfill 3 out of the 5 criteria. Exposure, PPD, signs and symptoms, X-ray, other laboratory findings, or other ancillary tests. What are these? Gastric AFB, sputum culture, TB culture, gene expert, or your PCR, so forth and so on. Okay? So, in practice, depending kung saan kayo practice, kung kompleto kayo lahat ng mga tests, yung iba gumagamit ka ng IGRA, yung mga mas bagong test in replacement of TST. Okay? So, usually here in the province, hanggang dito kami, yung 4 na yan. Okay? If you're able to fulfill 3 already, then you can classify na as disease siya. Okay? So, pag nag-PPD positive mo, mga exposure yan. So, exposure check, PPD check, symptoms check, X-ray check. Kung more than 3 ka na, 3 out of 5, you treat the patient as TB disease. So, yung patient natin kanina, may exposure ba siya? Nag-PPD positive siya. So, safe to assume na expose siya. Di ba? So, dalawa na. May signs and symptoms ba siya napasok? Yes. May X-ray ba siya suggestive of TB? Yes. So, 4 out of 5 mo na fulfill niya. So, you treat that as a disease. Okay? And mind you, before you say that your patient has signs and symptoms suggestive of TB, you have to fulfill 3 out of 6. Okay? Ang daming kailangan memorize. Cough for more than 2 weeks, unexplained fever for more than 2 weeks, common in children, especially young children, loss of appetite, weight faltering, failure to gain weight. Failure to respond to appropriate treatment for lower respiratory tract infection, failure to regain previous state of health after 2 weeks of viral infection, fatigue, reduced playfulness, lethargy. If you fulfill 3 out of 6, then saka mo pa lang siya may count dito as having signs and symptoms suggestive of TB. I hope that's clear. And how do you treat your TB? This is from the old regimen. I think we're familiar with this, category 1, 1A, 2, 2A, 3, something like that, di ba? Ngayon, again, going back to the manual of procedures, which I highly encourage you to read, ito na yung ginagamit natin. We are talking here for DSTB, drug-sensitive TB, because for MDR-TB, medyo mas masalimot yun. And I don't think that they will ask that in the board exam, dahil pag MDR-TB yan, dapat yan naka-refer yan sa specialist. Even at our levels, for general pediatricians, pag nakapag-diagnose kami ng MDR-TB, we usually refer it to infectious disease specialist, mga TB dot center. Okay? So let's focus on this, your drug-sensitive TB. Okay? You have two regimens, 4 HRZE plus 4 HR for a total of 6 months. Regimen 2 is 2 HRZE plus 10 HR. The difference is, regimen 2 is for your extrapulmonary of the CNS bones or joints. Okay? Ito, except CNS bones or joints. Okay? So, pulmonary or extrapulmonary TB, MTB, rifampicin sensitive, MTB, rifampicin intermediate, dito pa rin yan. Okay? New PTB or extrapulmonary PTB with positive sputum smear or TB lamp, okay? Or clinically diagnosed and the expert is not done or not detected, dito pa rin siya magpo-fall. Okay, so basically halos parehas lang yan. The only difference is this regimen is for your bones, CNS, and joints. Okay? The next few slides are simply dosing recommendations, especially in pedia. So nice to know, I don't think they will ask this in the exam. Okay? And usually meron ka rin mga single dose regimen or mga fixed drug combination. Okay? So here's a more detailed drug dosing, and this is what I personally use in practice, kino-compute yan. So just so you know, isoniazid, rifampicin, pyrazinamide, and ethambutol. These are the dose ranges. So 10, 15, it's actually 10 to 20, 10, 15, 35, and 20. Okay? So yan yung mga recommendations. And again, in children, guys, yun yung mas mataas usually yung dosage nila. Okay? Adverse drug effects and what to do. They usually ask this in the exam. Okay? So, ito yung adverse drug reaction, ito yung possible agent and what to do. So, if you have GI intolerance, usually rifampicin, isoniazid, or pyrazinamide, you can give it at bedtime or with small meals. Take note, isoniazid and rifampicin, they're usually and ideally given before meals in an empty stomach. Pyrazinamide and ethambutol can be given after meals. Okay? Mild or localized reaction, give antihistamine. All in colored urine, just observe and reassure. Burning sensation, make sure you give your pyridoxine, in which case most commercially available preparation, meron na yung kasamang pyridoxine. Arthralgia, due to hyperuricemia, you can give your NSAIDs. Okay? If persistent, consider gout and request for uric acid determination. Flu-like symptoms seen in rifampicin, you can give your antipyretics. Major reactions, severe skin rash, okay? Stop the drug and refer to specialists. Jaundice, okay? Stop the drugs, refer, and then usually dahan-dahan namin nire-resume yan. Meron pang cut-off yan kung gaano ka-elevated yung ALT, AST. Okay? Impaired visual acuity, stop ethambutol, refer to Opta. Oliguria, albuminuria, renal disorder, stop the drug, refer to specialist. Basically, for these major reactions, you have to stop the drugs and refer to specialists. So for the treatment outcomes, listed in this table are the outcomes. So it's cured, treatment completed, treatment failed, died, lost to follow-up, and not evaluated. Okay? So self-explanatory, guys. Basahin nyo lang ng part ito. Wala akong masyadong kailangan i-discuss sa part na yan. Okay? So, ito common na tinatanong, what do you do kapag na-interrupt yung treatment? So, this is a common board exam question which you all should know. So, if less than 1 month ang interruption, okay, just continue treatment and prolong to compensate for the missed doses. Okay? If more than 1 month but less than 2 months, you check for your smear microscopy. If negative yung smear microscopy niya, okay, sputum smear microscopy, okay, continue treatment and prolong to compensate for missed doses. If positive, okay, the question is how long has the patient been treated? Pag less than 5 months, continue and compensate. Pag more than 5 months na, tapos positive pa rin siya, treatment failure na yan. Okay? If more than 2 months na interrupt ang treatment, that is lost to follow-up. Okay? I hope this is clear. Okay? And another question that is usually asked, when do you follow up your sputum examination? For clinically diagnosed TB, repeat your sputum examination, okay, on the end of intensive phase on the 2nd month. Should you repeat your follow-up too? Only if positive at the end of the intensive phase. Okay? If positive at the end of the intensive phase, you repeat at the end of the 5th month and at the end of the 6th month. Okay? What about for new bacteriologically confirmed? So for bacteriologically confirmed or 4-week treatment, tatlo talaga yung follow-up. End of intensive phase, end of 5th month, end of 6th month. Okay? Your gene expert is not used for follow-up examination. Okay? Because current generation tests are unable to determine viability and may test positive even with non-viable or dead bacilli. Okay? So I hope we've discussed tuberculosis in children thorough enough for you to be able to confidently answer the questions theoretically and hopefully exercise your diagnosis of TB in patients when you go into your clinical practice. Okay? Kahit doon lang tayo sa diagnosis, guys. Malaman nyo na, ito TB to. Ito albuminuria, renal disorder, stop the drug. For clinically diagnosed TB, repeat your sputum examination, okay, on the end of intensive phase on the 2nd month. Should you repeat your follow-up too? Only if positive at the end of the intensive phase. Okay? If positive at the end of the intensive phase, you repeat at the end of the 5th month and at the end of the 6th month. Okay? What about for new bacteriologically confirmed? So for bacteriologically confirmed or 4-week treatment, tatlo talaga yung follow-up. End of intensive phase, end of 5th month, end of 6th month. Okay? Your gene expert is not used for follow-up examination. Okay? Because current generation tests are unable to determine viability and may test positive even with non-viable or dead bacilli. Okay? So I hope we've discussed tuberculosis in children thorough enough for you to be able to confidently answer the questions theoretically and hopefully exercise your diagnosis of TB in patients when you go into your clinical practice. Okay, kahit doon lang tayo sa diagnosis, guys. Malaman nyo na, ito TB to, ito hindi. Ito na-fulfill yung criteria, ito hindi. Tapos initial management, diba? So yung regimen 1 and regimen 2, dapat alam yun. Okay? So that's it. So let's go to our next case. You have a 2-year-old female who was brought in due to pallor for 2 months duration. So mga 2 months na lang napapansin ng parents niya na parang na namumutla siya. Okay? When you checked and plotted the anthropometrics of this patient, the weight and height are normal for age. And then the mother said that the diet consists mainly of formula milk because he's a very picky eater. So very common problem in children. Okay? So usually lalo na yung mga bata na hindi natuturuan kumain ng maayos, mind you, there's going to be a stage really na medyo magiging picky itong mga batang to, and usually pumapasok yan pagdating ng mga 2 years old, ganyan. Okay? But for these patients, one very common scenario that I see in my practice is, yun nga, hindi nila nata-transition yung milk feeding for the first 6 months of life, yung breast milk, tapos makakalimutan nila na 6 months onwards, kailangan na ng complementary feeding. And nakakalimutan nila na 1 year onwards, dapat yan, majority of the diet is solid food already. Dapat konting-konti na lang yung milk. Okay? Ano nangyari sa mga pasyenteng to? So, hindi naturuan kumain, hindi na tiyaga, minsan sinubukan ng pagkain, ayaw sumubo ng bata, gusto puro milk na lang. So, wala na, tuloy-tuloy na milk na lang yung kinakain ng bata or yung iniinom ng bata. And then this is very problematic because your milk will not be able to sustain all the macro and micronutrients that the body needs. You have to eat solid food, okay? And I always tell my patients na ganun po talaga yung mga bata. So pag binigyan mo ng pagkain, first time nila nakakain ng something, kunwari spaghetti, tas ayaw nila, it doesn't mean ayaw nila yan forever. So kailangan mo lang i-reintroduce, kailangan mo lang siyang i-retrain para kumain. Para nang sa ganun, yung diet nila magiging balance, okay? So going back to the case, on CBC, indeed there's anemia, sumaput lang talaga siya, may anemia siya. So what is your expected RBC morphology for this patient? Okay? So what disease process are you thinking about given na ito yung history or yung information na binigay sa inyo, di ba? So 2 years of age, which is a very common age group for this disease, okay? Exclusively milk-fed, almost exclusively milk-fed, presenting with anemia, and the rest of the findings are normal. Walang ibang findings na abnormal. So you should be thinking at this point of iron deficiency anemia. It's one of the most common causes of anemia in children, okay? And it's a nutritional disease. Dahil yun, kulang sila sa iron deficiency. And you would know that iron deficiency anemia would present as hypo, okay? Microcytic hypochromic anemia, okay? So there are a lot of approaches in dealing with patient with anemia, and one of the most common and easiest way to differentiate your causes of anemia in children would be to look at the size of the cells, okay? So you can classify your red blood cells as microcytic or small, normocytic, and macrocytic or large. And the value to memorize would be 80 to 100. That's the normal value. Below 80, that's microcytic. Above 100, that is macrocytic. Okay? A lot of times, dito iikot yung differential diagnosis nyo sa microcytic. Okay? Macrocytic is very easy. That's usually folate versus B12 deficiency. Okay? The difference is B12 presents with neurologic deficits. Folate wala siyang neurologic deficit. Okay? And other causes of macro would be drug and alcohol-induced anemia. Okay? Normocytic are the following. So bone marrow failure, hypothyroidism, anemia of chronic disease, uremia if your patient has kidney problem. Okay? Again, in children, a lot of your initial differential should be here. Okay? So ang mnemonics natin dyan ay tails. Okay? So thalassemia, anemia of chronic disease, iron deficiency anemia, lead poisoning, sideroblastic anemia. Okay? Your A is anemia of chronic disease. Doc, nasa normocytic siya. Yes, initially, it will present as a normocytic type of anemia, but in the long run, your anemia of chronic disease will become microcytic. Okay? So please do remember, age group, it's 9 to 24 months of age. The most common cause is dietary intake. Okay? The most important sign, this is from Nelson's, is your pallor. Okay? Pallor is usually seen when it reaches the level 7 to 8 grams per deciliter. So please take note of that. So yun nga, usually, anemic na yung patient pero wala ka pang physical signs and symptoms. So that's why a lot of times IDA is also missed out. And that's also one of the reasons why TPS suggests routine monitoring of CBC. So kung hindi ka pa nakakapag-check, for example, ng CBC ng patient, nag-check up sa'yo, nag-follow up sa'yo, at least, I think if I'm not mistaken, once a year, nandun yun sa PrevPed, sa handbook, nasa likod yun, may timing doon kung kailan kayo dapat nag-check ng CBC. Okay? So yeah, at 6 to 10 milligram per deciliter, so yan sabi dyan, compensatory mechanisms are in place. Usually wala pang symptoms yan, lalo na pag efficient yung mechanisms na yan. And usually, it becomes symptomatic at lower levels. So 7 to 8, at around 5, doon na pumapasok yung irritability, anorexia, okay? And the complications of IDA would be your cardiac dilation, okay, dilatation, tachycardia, and systolic murmurs, okay? So you have to watch out for that because we've seen several cases of patients na talagang hindi na correct yung IDA, napabayaan, and these patients go into cardiac failure, okay? So yan. So, how do you diagnose your iron deficiency anemia? Of course, there are a lot of tests that you can do. Definitely, syempre, gusto mo makita yung iron levels mo. So, that would be the best test, diba? To check for your iron levels or ferritin, okay? But these tests are not available readily in all institutions, okay? And usually, sa board exam, tinatanong nila, based on your CBC, your complete blood count, and your red blood cell indices, okay? Dapat kahit paano magkaroon kayo ng idea if this is a case of IDA or not, okay? And what do you see? Sabi natin, microcytic hypochromic anemia, okay? IDA presents as low reticulocyte count, okay? Reticulocyte is very important, okay? Normally, what's the response of your body to anemia? Normally, your reticulocyte should increase. Tama, di ba? Kasi reticulocyte are your immature red blood cells. So, as a compensatory mechanism, kapag meron kang anemia, your reticulocyte will increase. But in IDA, you have a problem in the bone marrow, di ba? If you have anemia and your reticulocyte count does not increase, it will tell you that probably you have a problem in your bone marrow. And ang IDA ba, may problema ka sa bone marrow? Technically, yes, kasi wala kang substrate to produce your red blood cells. Wala kang iron. So, yung bone marrow mo, hindi siya makapag-produce ng red blood cells. Okay? So, low reticulocyte count, microcytic hypochromic. And why is this highlighted? Increase in RDW. Because one of the most common differential diagnoses, if you're thinking of IDA, would be your thalassemia. Okay? And like IDA, thalassemia also presents with microhypo. It also presents with low reticulocyte count, but the RDW of thalassemia is normal. Okay? So, if you're not given iron levels, ferritin levels, TIBC levels, and you're simply given reticulocyte count, red blood cell indices, okay, you can differentiate IDA versus thalassemia by looking at the RDW. If your red cell distribution width is elevated, meaning the sizes of the red blood cells vary from each other, meaning may malalaki, may maliliit, if it's elevated, then probably it is iron deficiency anemia. If it's normal, then probably it's thalassemia. Okay? Why are TIBC capacity important? It says here your total iron binding capacity is high in IDA and low in chronic disease because both of these diseases will have low iron levels. Okay, and how do you manage it? So we've already discussed prevention. I've shown you a comprehensive slide during the earlier part of this lecture. The treatment is to give 3 to 6 milligram per kilogram per day of elemental iron in 2 to 3 divided doses. But again, there are some studies that have been showing that once daily dosing is more effective. Okay, maximum adult dose is 150 to 200 milligram per day, and we usually treat it for 2 to 3 months until your blood values have normalized. Okay, so here is a summary table showing you the difference of IDA and thalassemia, which is very important, very practical. You should all know this. This can be asked in the board exam. So IDA is nutritional, but you can have other causes such as parasitism, gastrointestinal bleeding. Okay, thalassemia is hereditary. Both are microcytic, hypochromic. Difference, RDW is elevated. Other tests that you can do, in IDA there's low iron, low ferritin, high total iron binding capacity. Thalassemia, of course, the definitive diagnosis would be your electrophoresis, and both will present with low reticulocyte count. Okay, so hope this is clear. Okay, next case, a child presenting with leukemia, okay, will most likely present with what signs and symptoms? Okay, can you have hepatomegaly? Yes, it's very common to have your organomegaly. GI bleeding, probably, if the patient is thrombocytopenic. Abdominal pain, yes, pwede rin yan. But the best answer among the choices would be letter A, an unexplained fever, okay, pallor, and hemorrhage. Okay, so unexplained fever, pallor, and hemorrhage. So this is explained because in leukemia, okay, usually present with pancytopenia, meaning all of your 3 blood cell lines are affected. Okay? So actually, technically speaking, technically speaking, when you say pancytopenia, it's two or more of your major cell lines that are affected. Ano ba yung mga major cell lines ng bone marrow? It's your red blood cells, your white blood cells, and your platelet. Diba? So if you have a patient that has a clinical picture compatible with leukemia, so meron silang weight loss, unexplained fever, pallor, bleeding, mga adenopathies, organomegaly, and then you check the CBC, tapos mababa, for example, yung hemoglobin, which is your red blood cells, and then mababa yung platelet, so dalawang cell line na yung affected, then you can consider na baka leukemia to. Okay? So, dahil yung mga cells ng leukemia, guys, these are blast cells, they are immature cells, wala silang function. So, pag mababa yung red blood cell, they have pallor. Pag mababa yung platelet, they can present with bleeding. Okay? Pag mababa yung WBC, they're prone to infection, or because of the inflammatory markers, the inflammatory cytokines produced by your tumor cells or your leukemic cells, you can also have unexplained fever. Okay, so there are a lot of causes of malignancy in children, but you have to know by heart your ALL, your acute lymphocytic or lymphoblastic leukemia. Okay, a lot of the questions in the board exam would probably be about ALL. So usually, they will ask you about your solid tumors. Ano ba yung mga solid tumors na kailangan alam nyo? That would be your hepatoblastoma, Wilms, and neuroblastoma, the most common abdominal tumors. Okay, your brain tumors are also very common. Okay, and for your non-solid tumors, you have to remember your leukemias, which ALL is the most common in children. So malamang dito siya magtatanong. They usually present as an acute onset of illness. So huwag kayong magtataka pag sinabi ng lola, ng lolo, na doc, last month okay po yung bata, wala siyang symptoms, 2 weeks ago lang po to, bigla siyang namutla, bigla nagkakaroon ng nose bleeding. It's common in ALL, okay? Most of the time it's non-specific. So anorexia, irritability, matamlay po siya, parang masyado siyang hindi siya madalas naglalaro, parang lagi po sumasakit yung tuhod niya, okay? And signs of bone marrow failure, which I already told you kanina, di ba? Anemia, bleeding, fever, okay? In ALL, it's very common to see signs of infiltration. When you say signs of infiltration, those are your bone pains, lymphadenopathies. Okay? Why is this important? You have another disease entity that also presents with pancytopenia. Bumabagsak yung mga cell lines nila. Ano yun? That's your aplastic anemia. Okay? And clinically, compared to ALL, your aplastic anemia, you don't commonly see signs of infiltration. Meaning, on history, on physical examination, wala yung mga hulani, wala yung mga bone pains, wala yung mga organomegaly. So, both will present with pancytopenia. Okay, one quick way to distinguish them would be the signs of infiltration. Again, this is not, of course, 100%. Na pag walang signs, aplastic anemia. Pag may signs of infiltration, acute leukemia. No, of course, it's not like that. Okay, of course, your definitive diagnosis would be to check your bone marrow. Okay, so your BMA, bone marrow aspiration. In which in ALL, what will you see? In ALL, you will see your blasts or immature cells, and in aplastic anemia, what will you see? It's hypocellularity and fibrophatic changes. Okay, so nagiging fibrofatty infiltration bone marrow niya. Tapos cellularity, konti yung mga cells. Whereas in leukemia, it's hypercellularity. Maraming cells pero puro mga blasts, puro mga immature cells. Okay. So, I've already discussed this. So, ito yung mga sinasabi ko. How do the manifestations manifest? How do the manifestations manifest? How do the symptoms manifest? Okay. You can have painless enlargement of the scrotum and CNS symptoms also in leukemia. Okay. This is very commonly asked in a lot of board exams. Okay. So, what is the most important prognostic factor for ALL? It's the treatment. Okay. So, it's the treatment that will be the most important prognostic factor. Okay. And other important predictive factors, the top 3 would be the age of the diagnosis. Okay. Pag masyadong bata or medyo matanda na, mas mataas yung risk. The initial leukocyte count. If your initial WBC is more than 50,000, okay, hindi maganda yan. And again, treatment is the most important prognostic factor. The response to treatment. So, kung paano siya mag-respond dun sa binibigay mong treatment. Okay. Average risk is between 1 to 10 with a leukocyte count of less than 50,000. Less than 1, medyo hindi maganda prognosis. More than 10, medyo hindi maganda. And pag mataas yung WBC, pag more than 50,000, that is what you call hyperleukocytosis. If the patient has hyperleukocytosis, then medyo hindi maganda prognostic factor yan. Okay? Commonly na tinatanong, site of relapse. Saan yung pinaka-common tatlo? Bone marrow, CNS, and testicular relapse. So bone marrow, central nervous system, and testis. Okay? Other sites, aside from these 3, where does it spread? Liver, spleen, and lymph nodes. Okay? So here are the poor prognostic factors that you should know. So dapat alam niyo yung top 3 na good prognosis, okay? Important predictive factors, and then yung poor prognosis. Okay? Less than 2, more than 10, male, WBC of more than 100,000 on presentation. Okay? Sabi ko kanina 50. No? 50 is the cutoff for hyperleukocytosis. More than 100,000 pala yung pag hindi magandang prognostic factor. So WBC more than 100,000, CNS leukemia, and if you have a mediastinal mass. Okay, that's also poor prognosis. Okay, so please do remember all of those important factors for ALL. It's a quick discussion, but those 4 to 5 slides, those are very high yield. I guarantee you a lot of the questions will hopefully be coming from those topics that we discussed for ALL. Okay. Okay, next case, you have a 3-month-old baby boy who was brought in for jaundice. Okay, so if you have a patient with jaundice, dapat automatic may line of thinking ka na, may flow of thought ka na. So, ang unang tanong dyan, is this physiologic jaundice, lalo sa mga newborn, or is this pathologic? Okay, he developed jaundice on the 10th day of life, so medyo late na siya nag-develop. Exclusively breastfed, and pinaparawan naman daw siya ng mga mother. Okay, so mother reported dark stain in urine, okay, and whitish stool, which she thought were normal. Okay, so at this point in time, are you still thinking of physiologic jaundice? So dapat hindi na. Okay, at this point in time, may mga factors na dyan na na-ekis mo na. So age pa lang, 3 months old. So 3 months old na may jaundice pa rin. That's more than 2 weeks. More than 2 weeks old, may jaundice. 90% to 95% of the time, then probably that's pathologic. Okay? Kasi dapat hanggang 2 weeks lang yan eh. There is one disease, well, it's not a disease entity. There's one physiologic cause of jaundice that can extend up to more than 2 weeks, some up to 3 months pa nga. That is breast milk jaundice. Okay? But please do remember that your physiologic jaundice, it's a diagnosis of exclusion. Before you say or label na physiologic jaundice to, dapat 100% na-exclude mo na lahat ng mga pathologic causes. So, gaya nitong patient na to, so sabi mo, sige, 10th day lumabas, baka physiologic yan, kaya lang 3 months old na siya. Okay? May question mark ka dun. So, if you're not sure, then it's better to lean towards the pathologic side. Kasi merong something na doesn't make sense. So, you have to work up this patient. And then, binasa mo pa yung case, nakita mo meron siyang dark urine and alcoholic stools. Automatic. Dapat at this point, sure ka na hindi to physiologic jaundice. Okay? The child is well, no fever, good appetite and activity, unremarkable history, full term siya. On PE, there's generalized jaundice and hepatomegaly. So at this point, wala nang question. Mataas yan. Okay? That's already pathologic. Okay? You did your bilirubin test, which is very important. Okay? Your total is 15, which is high. The direct is 10, and the indirect is 5. Okay? In jaundice in the newborn, kapag yung mga jaundice sa babies, okay, ano ba yung mas tumataas? Is it the direct or the indirect? You have to know this. Okay? In newborn, mas tumataas yung indirect. Okay? Your direct bilirubin, as a matter of fact, if it is elevated, it is always, okay, pathologic. Okay? If the direct bilirubin is elevated, it is always pathologic. Please take that down. Okay? So sulat yun. So if the direct is elevated, it's always pathologic. And how will you know if the direct is elevated? I will have a slide to show you that. Okay? So what are your possible differential diagnoses? The following are possible differential diagnoses except, so it's of course your breastfeeding jaundice because it's physiologic, and we've all established that this is pathologic jaundice. This is probably cholestatic. Meron kang cholestasis. Okay? And all of these, bakit siya meron cholestasis? Kasi nga mataas yung direct. Okay, so pag mataas ang direct, cholestatic jaundice yan. Okay, and all of these diseases, neonatal hepatitis, biliary atresia, Alagille syndrome, all of these diseases are cholestatic jaundice, or diseases which have cholestasis as a common feature. Okay, so cholestasis is the prolonged elevation of bilirubin. Okay, specifically your conjugated bilirubin beyond the first 14 days of life. Okay. The common pathophysiology is obstruction of blood bile flow. Okay, so it can be either mechanical, such as what you see in biliary atresia, wherein ang problema mo is yung anatomy ng biliary tree mo, or it can be because of an impaired hepatic function. So hindi gumagana yung liver, hindi niya ma-excrete yung bilirubin. Okay, so ito yung common na pathophysiologic explanation. Okay, this slide is very important. You have to be able to differentiate physiologic from pathologic jaundice, and there are a lot of qualifiers for you to say if it's physiologic or pathologic. And what is the most important thing that I teach my students? It's that physiologic jaundice is a diagnosis of exclusion. I've already said that kanina. And for you to label it as physiologic jaundice, you have to fulfill everything, okay, in this column. To label it as pathologic, you only need one. Okay? Isa lang yung ma-fulfill mo, pathologic na yan. And so, how do I memorize it? Ako, tinatandaan ko lang pathologic. Kasi kahit anong isa dyan, pathologic na siya. If wala lahat to, then it's physiologic. So, 24 hours, okay? If it appears on the first 24 hours, that's pathologic. If your bilirubin is rising more than 5 per day, that's pathologic. If the total is more than 12 or 10 to 14 in preterm, that's pathologic. If the increase is more than 0.5 per hour, that's pathologic. And if jaundice lasts for more than 14 days. And lastly, if your direct bilirubin is more than 2 at any given time. So, yan. Pag yung direct mo more than 2, then that's pathologic. Yung pasyente natin kanina, yung direct is 10. Okay? So, I'll give you an example. Let's do some examples para mas malinaw, para mas maintindihan yung sinasabi ko. Nagkaroon siya ng jaundice on the first day of life. Pathologic? Of course. Okay, next case. Nagkaroon siya ng jaundice on the second day of life. You check the total bilirubin, it's 7. Okay, so second day of life na siya. Chinek mo yung total bilirubin, 7. Okay, it's less than 12. Okay, can that be physiologic? Parang pwede pa. Okay, the next day, you checked. Yung 7 niya, naging 13. Okay, is it pathologic? Yes. Bakit? Ito parang pwede pa naman yung 14, di ba? Preterm yan. Hindi ko sinabi kung preterm or full term. Pero ano yung mas importante doon? Bakit ko sinabi na with conviction na pathologic yun? Yung 7 mo naging 13. That's more than 5 in 24 hours. Okay? Ibig sabihin, naka-fulfill siya ng isang criteria. Ibig sabihin, pathologic na yan. I hope that is clear. Huwag malilito sa exam. Okay? Because sometimes they give out cases na yung bata nag-jaundice on the second day of life, meron siyang sepsis, may growth na blood culture, the bilirubin level is 10, okay? So forth and so on. And then, a lot of the students will answer, baka physiologic to. Pasok siya dun sa mga criteria na physiologic. Then they forget the most important fact, which is what? Sa case na yun, yung baby may sepsis. Okay? So the baby is not well. May infection siya. Kung may infection ka, it will cause jaundice. So probably for that baby, that is pathologic jaundice. Is that clear? So I hope that's clear. Okay? So again, in newborns, okay, what do we measure? Sorry for that. Okay. In newborns, okay, so in newborns, what is the most important thing that we measure? Because bilirubin, as we all know, is composed of your indirect or unconjugated or B1, pare-pares lang yun, okay, malito, or the direct or conjugated or B2. Okay? The total is simply your B1 plus B2. Okay? So what is more important? Okay? Kapag ang tanong is to determine whether that baby needs phototherapy or not, the management for hyperbilirubinemia, for indirect, which is more common in newborn, the indirect hyperbilirubinemia, the management of that is phototherapy. But pag tinanong kayo, ano ba yung basis natin? When we plot it in the Botany chart, that's what you call your Botany chart, BHU-TANI, Botany chart. We look at the total. So please remember that if our decision making for phototherapy, okay, pag tinanong kayo, where is your decision making for phototherapy based? Is it the total, direct, or indirect? It's actually the total. Okay, but you have to know the difference between direct and indirect. Okay, again, indirect is lipid soluble. Because it's lipid soluble, it crosses your blood-brain barrier. That's why it's prone, or it's more dangerous, because it might reach the brain. It might cause the complication of hyperbilirubinemia in newborn, which is your kernicterus pathologically, or clinically you call it bilirubin encephalopathy. Okay, so bilirubin encephalopathy, or pathologically kernicterus. Kernicterus is the deposition of your bilirubin in the basal ganglia. Okay, so yun, that's kernicterus. On the other hand, your direct, conjugated, or your B2, it's water soluble. It does not cause the blood-brain barrier. But what is important to remember is that if it is elevated, and by definition, if it's more than 2 milligram per deciliters, according to Nelson, if it is elevated, then that is always pathologic. You have to rule out for your cholestatic causes of jaundice. Okay, so going back to neonatal cholestasis, the broad classification would be your intrahepatic and extrahepatic disease. Intrahepatic sa loob ng liver, extrahepatic sa labas, sa biliary tree yung problema. And when it comes to these two broad classifications, you have to know at least theoretically the difference between neonatal hepatitis and biliary atresia. Kasi yan yung mga representative diseases ng neonatal cholestasis. Okay? Biliary atresia, also known as your non-cystic obliterative cholangiopathy, there are different types. Okay? The most common form is this obliteration of the entire extrahepatic biliary tree at or above the porta hepatis. Very common board exam question yan. So you have to memorize that pathology. So saan ba yung sira sa biliary tract niya? Kasi sabi natin extrahepatic siya, di ba? So it's the entire extrahepatic biliary tree. Okay? A lot of these patients are normal at birth and there's postnatal progression. So ito yung mga baby na okay sila habang tumatanda, dok, nagiging acolic yung stool, tapos lumalabas yung jaundice. Okay? So for those with postnatal onset, it can be immune or infection mediated. Okay? Biliary atresia versus neonatal hepatitis is actually very difficult to differentiate clinically. And even with your lab test, there is no single biochemical test that will distinguish your biliary atresia versus neonatal hepatitis. Okay? One of the common questions that we see or we hear in the board exam and in your clinical rounds is that, do you do ultrasound for a patient whom you are suspecting biliary atresia? Okay? The answer is yes, you do your ultrasound. Okay? But if they ask you, is it diagnostic? The answer is no. It's not diagnostic. In fact, it's very hard to see on ultrasound if this patient has biliary atresia. You're lucky if you find your triangular cord sign. Okay, it's a cone-shaped fibrotic mass, okay, cranial to the bifurcation of the portal vein. If you see this, then probably it will give you a hint that it's biliary atresia. But again, a normal ultrasound does not rule out biliary atresia. Okay, why then do we do ultrasound if you're suspecting biliary atresia? Okay, it's because of this, to rule out other surgical causes of cholestatic jaundice, such as choledochal cyst. Kasi pag choledochal cyst yan, guys, alam mo na kung ano yung nagkakos ng cholestasis niya. So choledochal cyst, surgical, in-extract yung cyst, in-excise yung cyst. Malinaw? So there are a lot of tests that we do, hepatobiliary scintigraphy, such as your HIDA scan. Okay, biopsy is important, okay, to differentiate between the various causes of cholestasis. But if they ask you what is the gold standard, okay, a lot of diseases ang gold standard biopsy, diba? But if they ask you for biliary atresia, what is the gold standard? Please remember that the answer is cholangiography. So you have to visualize the extent of damage. Okay, and here's a table summarizing the difference between the two. So please remember that biliary atresia is extrahepatic, neonatal hepatitis is intrahepatic. Okay, familial incidence, namamana, mas common siya sa neonatal hepatitis. Prematurity and small for gestational age, mas common sa neonatal hepatitis. Persistent alcoholic stool, ang biliary atresia tuloy-tuloy. Ang neonatal hepatitis, ang alcoholic stool nila on and off. Okay. And of course, again, we go to the biopsy. And please remember the striking difference between the biopsy of the two. In biliary atresia, huwag kayong malilito kasi sabi dyan, biliary atresia, there's bile duct proliferation and your hepatic structure is intact. The exact opposite can be seen in neonatal hepatitis, wherein there is severe hepatocellular disease and little bile duct alteration. Okay? I hope that is clear. Okay? So the management is, of course, nutritional support, very important. These patients with progressing liver damage are very prone to developing your vitamin deficiency, specifically what type of vitamins, your fat-soluble vitamins, your ADEC. Okay? And of course, laging tinatanong sa exam was your Kasai procedure, your hepatoportoenterostomy. So ano ba nangyayari dyan sa Kasai? So ayan yan, this is the before surgery, this is the after surgery. Your small intestine is connected to the liver to allow the bile to drain. Kasi nga, in biliary atresia, ang problema mo, yung extrahepatic bile trees mo sira. Diba? Damage or block. So ang gagawin mo, idediretso mo na yung bituka dun sa liver. Please do remember that the golden period is 60 days. According to Nelson's, okay, much higher, 90%. If performed before 8 weeks of life, the success is much higher. Kaya a lot of exams would look for the 60-day magic number, golden period to perform Kasai. But also, please remember that Kasai is not the definitive management. Pangtawid lang yan. The definitive treatment, if they ask you what is the definitive management for biliary atresia, it's liver transplant. Okay, next case, you have a toddler who was brought to you for multiple bouts of watery diarrhea without vomiting. Okay, so I'll say it right now, guys. If you have a patient who is having diarrhea, if it's non-bloody, then one of your first differential diagnoses should be your viral gastroenteritis. And in young children, the most common cause of viral gastroenteritis is rotavirus. So very important yan, guys. Okay, pag may batang nagtatae, then probably that is viral. Why am I repeating this? Viral infections do not need antibiotic management. So I'm constantly seeing a lot of patients with watery diarrhea being managed with antibiotics. Hindi yun makakatulong, guys. Okay? So if it's not infectious diarrhea, if it's not bacterial, if it's viral, which is again the most common cause of watery diarrhea in children, then probably that's rotavirus. Usually it's self-resolving. Your goal is to keep the patient hydrated. And we will discuss the management later on. So let's go back to the case. So toddler with multiple watery diarrhea without vomiting, you're thinking of rotaviral infection. On examination, he's tachycardic, weak, pulses, reduced turgor, sunken eyes, lethargic but irritable to touch. And then when you gave your ORS, your Oresol, he gulped it vigorously. So what is your assessment? You are being asked what the degree of dehydration for this patient is. And when you see the terms no dehydration, some dehydration, and severe dehydration, those are terms from the WHO guidelines of acute gastroenteritis. Okay? Because sometimes students confuse it with the other parameters to monitor your fluid status or your dehydration status. Such as, for example, holiday cigar, di ba? Na sa holiday cigars and Nelsons, ang kanilang terms that they use would be mild, moderate, and severe dehydration. Tama? Pero pag no, some, saka severe, then probably that is the WHO guidelines. Okay? So, strictly speaking, when we use the WHO guidelines, this patient will fall onto some dehydration because the patient has reduced turgor, sunken eyes, lethargic, okay, pero irritable, okay, and gulps vigorously, diba? Thirsty siya, okay? But clinically, if I were to be the doctor to see this patient, I can also classify this as having severe dehydration. Bakit? Weak na yung pulses niya, tachycardic na siya, diba? These are already signs of compensated shock. Okay, your patient might still be having normal blood pressure, pero the compensatory mechanisms are kicking in na, nagtatachycardia na, mahina na yung pulse, so shock na yan, compensated shock ang tawag dyan. But we're discussing IMCI, we're discussing WHO guidelines. The answer would be some dehydration. And here is how WHO classifies it. Please do remember that you have to fulfill 2 of the following signs before you can classify it as having severe or some dehydration. And for WHO, they keep it simple. You only have to monitor 4 parameters. My mnemonics for that is SETS, SETS, SETS. Okay? Sensorium, eyeball, turgor, that's your T, and thirst, and S, skin turgor. Okay? So again, sensorium, eyeball, thirst, and skin turgor. Yun yung 4. Okay? So when you classify, it's usually best to start with the more severe classification, and then you see if hindi siya pasok dito, saka ka bababa. Okay? So when you're classifying the patient, 2 or more of the following. Do take note, yung severe saka yung some, guys, halos parehas lang yan. Parehas yan na sunken eyes, parehas yan na slow yung turgor. Okay? So again, parehas na sunken eyes, parehas na sunken turgor. Saan lang sila nagkakaiba? Nagkakaiba lang sila sa sensorium saka sa thirst. Ang severe dehydration, siya ay abnormally sleepy, difficult to awaken. So lethargic siya. Yung kanina magulo, no? Lethargic pero irritable to touch. Ang weird, no? Okay? Tapos, yung kanyang thirst does not drink. Ayaw uminom kasi sobrang pagod na niya, sobrang lethargic na niya. Versus some dehydration, it's more of irritable and very thirsty. So dito pumapasok yung pasyente natin. Irritable to touch tapos thirsty siya. Okay? So for example, I have a patient, awake, active, okay? Hindi siya sobrang thirsty, normal lang yung inom niya, normal yung turgor pero sunken yung eyeballs. How do you classify that? Sunken eyeballs, yun lang meron sa kanya. Okay? You classify that as having, okay, no dehydration. Kasi hindi ka nakadalawa eh. Dapat 2 of the following. So technically speaking, no dehydration yan. Okay? And why is this very important? Because we treat the patient depending on the classification. Okay? So if it is no dehydration, treatment plan A. If it's some dehydration, plan B. If it's severe, plan C. Okay? And what do you give for plan A? Okay? Remember the 4 pillars of managing acute diarrhea in children. Ano yung 4 pillars? Number 1, Oresol, your oral rehydrating solution. Number 2, it's zinc. Okay? Both Oresol and zinc will decrease the amount and volume of stool and even vomiting. Okay? Number 3, ano yung number 3? Continue nutritious feeding. Okay? You don't need to put the patient on NPO. Baliktad nga, when the patient has acute gastroenteritis, when the patient has an illness, mas mataas yung metabolic demands ng katawan. So mas kailangan marami yung intake mo. Dapat mas maganda yung intake mo. So walang bawal. Okay? Because there are some patients na pag yung mothers yung fathers nila, akala nila pag nagtatay, bawal kumain ng ganito, bawal kumain ng ganyan. Sobrang daming bawal, wala na nutritional intake yung bata. Okay? Recovery is faster kapag may solid, may oral intake yung bata as compared to NPO. Okay? So number 4, it's to reassess and refer. You have to know when to reassess kasi baka yung nasa plan A mo, after 4 hours, baka mamaya plan B na pala siya. Okay? Nagsasam dehydration na siya. So again, please remember the 4 pillars. Orisol, zinc, okay? Continue nutritious feeding, know when to refer, and to reassess. Okay? And of course, the most important, that's why we're classifying actually the level of dehydration, is to be able to know, okay, how much of orisol should you give and how much should you give for treatment plan A. Okay? What we tell our patients, di ba, pag nag-ambulatory clinics tayo, okay, or even in the ER, di ba sabi natin, mommy, daddy, volume per volume replacement. Are you familiar with that? Di ba? Volume per volume replacement. Tama. What goes out, ideally should be replaced. Okay? However, practically speaking, medyo mahirap yan, guys. Ang hirap kaya magpa-volume per volume replacement, di ba? So, imagine niyo yung hassle kung kayo magulang, may sakit yung anak mo, tapos gusto mo sabihin ng doktor mo, mami, bawat dumi niyan, sukatin mo. Okay, dok, wala po akong timbangan. Hindi, mami, bumili ka ng timbangan. Kailangan eksakto tayo, volume per volume replacement. Okay? Hindi yan practical, guys. Hindi yan practical. Luckily, may guide tayo. So, pag tinanong kayo, gano'ng karami po ba? If less than 2 years old yung bata, mami, mga 50 to 100 ml ang kailangan nyo ibigay ng orisol. Okay? So, that's roughly 2 to 3 ounce. Okay? Kapag 2 to 10 years old, mami, mga 100 to 200 ml. So, that's around 3 to 6 to 7 ounces. Okay? And pag more than 10 years old, as much as they want. So, di ba mas madali? Okay? So, after each loose stool, okay, this is the amount of orisol that you should be replacing. Okay? If your patient has some signs of dehydration, what should you give for rehydration as replacement? Okay? Should you give IV hydration or still orisol? Okay? Your answer should be it's still ORS. Okay? And the question is kapag some dehydration, okay, pag some dehydration, the question is how much orisol do you give? And here's the formula in your screen. It's weight in kilograms times 75. Okay, to be given usually for 4 hours. So if you see a child with some dehydration, okay, 10 kilogram, mami, we are going to give her 750 ml of orisol. Okay, to be given in 4 hours. Dapat po in 4 hours time, maubos niya yan because that's the fluid deficit of your child. Okay? Dok, paano kung habang 4 hours na yun, dumudumi pa siya? So on top of the 750 ml, dapat meron ka pa ring replacement na, ito, volume per volume. Okay? If your patient comes into you severely dehydrated, and this is how you do it. And for these patients, the fluid of choice now is via intravenous route. Okay? What fluids? It's either plain NSS or plain lactated Ringer solution. That's the safest answer. Okay? NSS or LR, plain. Do not use dextrose containing fluid if your patient has severe dehydration. Okay? Because for these patients, ang goal mo is volume resuscitation. You have to replace the intravascular volume loss. Okay? What's the problem with your D5 containing solution? Okay? Yung mga dextrose containing solution, mataas ang kanilang diuretic, they induce diuresis. So, yung chance na ma-retain mo yung volume na pinasok mo, pag dextrose containing yan, because of the dextrose, taas yung osmolarity niya, iihi niya na iihi yan. So, hindi magtatagal yung fluid sa loob. That is why if your patient has severe dehydration, if your patient is in shock, for example, hypotensive, when you're going to do fluid resuscitation, please choose your plain fluids. Which one? You can either go with NSS or LR. Okay? If you're not sure, the safer guess would be plain NSS. Okay? What's the problem with LR? May potassium si LR. So if your patient is undergoing renal failure, kung may acute kidney injury siya, tapos nagpasok ka ng maraming potassium, baka magkaroon ng hyperkalemia yan. Okay? So if you're not sure NSS or LR, better bet would be NSS. Okay? But you can still use LR. Okay? So yan. So please remember that. For volume resuscitation, for severe dehydration, if the patient is less than 12 months, or some references would say, dagdag nyo dyan, less than 10 kilograms, we give it more slowly. 30 ml per kilo. So for example, sabihin natin yung pasyente mo is 10 kilograms. Okay? So 30 ml, 300 ml to run for 1 hour, 700 ml to run for 5 hours. Ganun siya. Okay? So after the first hour, yung 700 ml mo, to run mo naman siya for 5 hours. If it's an older child, more than 10 kilos, mas mabilis ka na. Okay? So for example, 20 kilos, so 20 times 30, 600 ml to run for 30 minutes. So parang fast drip yun, diba? And then 70 times 20 to run for 2.5 hours. Okay? So please remember that. Okay? NSS and LR, they are considered isotonic fluids. Please do use isotonic fluids for volume resuscitation. Do not use hypotonic fluids such as D5.3, D5-IMB. Those are hypotonic solutions. Okay? Hindi siya maganda for volume resuscitation. Okay? Pag hypotonic siya, malaki yung chance na hindi siya mag-maintain into your intravascular volume space, your intravascular space. Baka magtapon lang siya palabas, so hindi mo ma-fulfill yung goal mo, which is to restore your volume. Okay? So hindi ka pwede magbigay ng hypotonic for volume resuscitation. Dapat yan, isotonic solution. Okay? So please remember that. ORS is very important. Okay? If it's some signs of dehydration, you use ORS. If it's no sign, you use ORS. If your patient has severe dehydration and you do not have any IV access, ano yung recommendation ng WHO? So for example, lethargic, hypotensive, tapos kailangan mo pa siyang dalhin sa hospital, which is 2 hours away, wala kang swero, wala kang IV access. Some references would say sa MC, you put your OGT or NGT, tapos you can give your ORS, dahan-dahan. Okay? Pwede pa rin, orisol. Okay? And please do take note of the difference. Okay? The old orisol and the new orisol, it's called your reduced osmolarity ORS from 311 to 245. This is very important. They ask this in some exams. Okay? I think 3 years ago, lumabas ng question na to. So ano yung difference ng osmolarity ng old sa reformulated? So why? They have seen that reduced osmolarity orisol, okay, is better and quicker absorbed by your intestines. Mas madali siya na-absorb. Kasi di ba, pag mataas yung osmolarity, what is the tendency? Ang tendency niyan, maghahatak siya ng fluid. Mas malaki yung chance na maghahatak siya ng fluid. So yung sa tiyan mo, naglagay ka ng mataas yung osmolarity, instead na ma-absorb siya, maghahatak pa siya ng fluid, lalo magtatae. Okay? They have seen that reduced osmolarity is better. Mas na-absorb siya, mas mabilis. Okay? And how do they achieve this? Ano yung binawasan nila? It's the glucose and the sodium. From 111 to 75, from 90 to 75. Okay? Ito, nag-adjust din yung mga yan. Chloride bumaba din, potassium and citrate, they remain the same. So ito yung pinaka-importante, glucose and sodium. Okay? And another change in the reformulation is that they changed the ratio of your glucose and sodium to 75-75, 1:1. Okay? 1:1 ratio of your sodium and glucose. This is theoretically to maximize the sodium-glucose co-transport in your intestinal mucosa. Okay? Dahil sabi natin, di ba, where sodium goes, water follows. Okay? So yun yung purpose nun. So na-utilize mo yung sodium-glucose co-transport. So pagpasok ni sodium paloob, hahatakin din yung tubig para mas mabilis mag-replenish ng intravascular volume. So for our next case, you have a 2-year-old boy who was brought in the ER with a 4-day history of cough and fever. At the ER, The patient is irritable in cardiorespiratory distress with a heart rate of 140, that's tachycardic, R of 50, that's tachypneic, temperature of 38, and a room saturation at room air of 90%. There's noted alar flaring, subcostal retractions, okay? There's equal chest expansion, good air entry, and there's firing crackles on bilateral lung field. The rest of the physical examination is remarkable. Your impression is, okay, so this is pretty straightforward. All of your choices are PCAP, diba? Mayroon siya dyan, PACP. Probably that's still PCAP, typographic error lang yan. So it's PCAP, A, B, C, or D, okay? So if the choices are not there, would you know that this is pneumonia? Of course, diba? You have a patient with cough and fever. The patient is tachypneic, which is very sensitive for pneumonia. So please remember when they ask you, across all age group, ano yung pinaka-sensitive na physical examination finding for pneumonia? Meaning, across all age group, ano yung most likely na nandun? And the answer for that would be tachypnea, okay? So hindi lahat ng pneumonia nagkakaroon ng crackles, hindi lahat ng pneumonia nagkakaroon ng fever or ng cough, okay? But across all age group, nakita ng mga pag-aaral na usually meron yung tachypnea. It's very sensitive. It's a sensitive indicator for pneumonia. Okay? So when you have a patient with alar flaring and subcostal retractions, these are called the use of your accessory respiratory muscles. Okay? These are your accessory muscles for respiration. So your patient, okay, because of the pneumonia, there is a ventilation perfusion mismatch. Your patient tries to compensate, di ba? Para mas maganda yung ikot ng oxygen or mas maparami niya yung oxygenation ng blood, he compensates by how? By several mechanisms. Tachypnea is one, okay? The use of accessory muscles is another, di ba? Our main muscle for respiration is our diaphragm. Pero pag hindi na kaya ng diaphragm, kailangan mas magtrabaho ka. That's why you have your subcostal intercostal retractions, okay? That's why you have alar flaring para lumaki yung butas ng ilong, mas technically mas maraming hangin yung papasok. So yun yung mga reason kung bakit tayo nagkakaroon ng ganitong findings. And when you put all of this case together, the answer should be your C, di ba? So your PCAP C, moderate risk, di ba? There's mild, moderate, and high risk, okay? So low risk, moderate risk, and high risk. So PCAP C, okay? So I've mentioned this before. So across all age group, tachypnea, okay, is the most common and most sensitive indicator that you can see, okay, across all age group. And there are different cutoff ranges in tachypnea in children, depende kung ano yung binabasa nyong guidelines, okay? So these are the guidelines from PAPP, Philippine Academy of Pediatric Pulmonologists, okay? So tachypnea in 3 to 12 months is more than 50, in 1 to 5 years is more than 40, in more than 5 years is more than 30, and in 10 years old pataas, adolescents to adult, okay, it's more than 20. So parang adult value na yan. So it's very easy to remember these tachypnea cutoff, okay? Neonatal period is 60, so it's 60, 50, 40, 30, 20. 60, 50, 40, 30, 20, okay? 60, 50, 40, 30, 20, and 60. Neonates, 0 to 2 months, 60. 3 months to 1 year old, 50, okay? 1 to 5, it's 40. 5 to 10, okay? It's 30. 10 pataas, it's 20, okay? So 0 to 2 months, 3 to 12 months, 1 to 5, 5 to 10, 10 pataas. Again, neonates 0 to 2 months of age, that's 60 ang cutoff natin, okay? 3 months to 1 year old, that is 50. 1 to 5, that is 40. 5 to 10, okay, that is 30, and more than 10, or your adult cutoff, that's 20, okay? So again, these are your accessory muscles for respiration, retraction, head bobbing, okay? If you have subcostal and supraclavicular, okay, that is high risk or very severe pneumonia, PCAP D. So please, huwag niyo pagpapalit-palit yung mga terms na yan, depende lang sa guidelines yan. So non-severe, severe, very severe, pero ang mas common na ginagamit is low risk, moderate risk, high risk. PCAP A, B, C, and D, okay? So dito sa mas recent na guidelines, meron kayong mga altered sensorium or the presence of convulsions, okay? Circulatory signs, general condition. Pag may malnourished yung patient, automatic B yan, okay? So pag mild, pag moderate, that's C. Pag severely malnourished, that's D, okay? Inability to drink is also here, and comorbid conditions, okay? In the latest guidelines, they also included your radiographic findings if you have effusions, abscess, air leak, and consolidation, okay? As well as your on-the-spot oxygen reading using your pulse oximeter, okay? So 91 to 94 are normal cutoff for pulse oximetry value for non-neonatal patients. Sa neonates, hanggang 92% pwede, pero sa non-neonates, which means 3 months pataas, 95% ang ating normal O2 saturation sa pulse oximeter, okay? 91 to 94 is moderate risk, and less than 90 is high risk, okay? So please remember these important nitty-gritty details that's written under that table. If you look at the guidelines, sabi dyan, to classify higher, you have to fulfill at least 2 parameters. Okay? Sabi din dyan, after 48 hours, if your A and B is not responding to treatment, so after 2 days, you may admit the patient. And sabi din dyan, PCAP C may actually be managed as outpatient if all are present. Okay, sorry, if all are not present. So pag not present lahat ng features na to, ibig sabihin more than 2, walang seizure, yung X-ray niya, walang effusion, walang abscess, walang consolidation, at yung oxygen sats niya, okay, even if it's PCAP C, technically, okay, strictly speaking, you can manage it as outpatient. Okay? But for me personally, I admit my patients who are PCAP C. So medyo mas risky kasi yan. Pero yun nga, studies have shown na technically pwede. Okay? Pero pagdating sa preference, personally, pag PCAP C na-admit ko yan. Okay? Please do remember the drugs that we use. Okay? For A and B, it's amoxicillin. Okay? Because pag tinanong kayo, ano bang organism ang pinaka-common na nagkakos ng pneumonia sa mga bata? Okay? When we're talking about bacterial causes, then pag tinanong kayo, overall, ano ba yung pinaka-common na cause ng pneumonia? Your answer should be viruses. Okay? Pero pag tinanong kayo, bacterial causes ng pneumonia, that's why we're giving antibiotic, it still remains to be your Streptococcus pneumoniae, strep pneumo. And will amoxicillin cover for that? Yes, actually, amoxicillin still has a good sensitivity for your strep pneumo. Okay? That's why I hope you guys trust and still use amoxicillin. Of course, you can shuffle with your cephalosporin, such as your cefuroxime. Okay? Pero I don't think there's a need na tumaas pa kayo doon because I see a lot of people giving left and right co-amoxiclav for pneumonia, lalo na pag wala pa namang previous antibiotic intake. Masyado mataas yun, guys. Your amoxicillin will work. Okay? If your patient is allergic to amoxicillin, you can give your macrolides, such as your clarithromycin. Okay? For PCAP C, those who are admitted, it will depend on your Hib vaccination status. If he is completely vaccinated against Hib, then PenG would suffice. If not, the IV form of amoxicillin, which is ampicillin, is to be used. Okay? I hope malinaw yan. Next case, you have a 1-year-old female who was rushed to the emergency room. Patient had 2-day history of cough, colds, high-grade fever with a maximum temperature of 39 degrees Celsius. Few hours prior to consult, he developed seizures described as generalized tonic-clonic with upward rolling of eyeball. At the ER, the patient was awake but irritable. Neurologic PE is unremarkable. Systemic PE is likewise unremarkable. What is your impression? So this is a 1-year-old female developing fever and convulsions. Okay? The duration is not stated there. Okay? Pero yun nga, gising na siya pagdating, neurologic PE is unremarkable. What would be the best answer here? Okay? So at this point in time, yung tinatanong sa inyo, so during this point in time, wala pang ibang information needed given. Okay? The best answer would be your benign or your simple febrile convulsions. Okay? you have to know the definition of your BFC or your SFS. It's the same, so simple febrile seizures or benign febrile convulsion. Okay, it's the most common seizure disorder of childhood. Okay, the exact mechanism is not known, pero it's of course related to the fever. It's the one causing the seizure. But please do remember that all of the recent guidelines will suggest that giving round-the-clock antipyretics will not be of much help. Okay, hindi siya nakakatulong. So ang advice pa rin ng mga society, ng mga recommendation would be to give your paracetamol PRN. Okay, PRN, yeah, as needed. Okay, the age group is very important. It's rare before 9 months and after 5 years of age. So if you have a patient developing febrile seizures in less than 9 months, then you have to be wary. Ingat ka, baka mamaya bacterial meningitis pala yan. Okay, and if you have a patient still continuing to have BFC beyond 5 years of age, baka hindi na BFC yan. Baka may epilepsy syndromes na yan. Okay, so you have to work those up. Okay, and you have to fulfill this criteria. Okay, it's usually generalized tonic-clonic. It shouldn't be focal. And how would you know if it's focal? Paano yung tinatanong niyo sa mga parents? So yung gaze niya should be upward gaze. It should not be left or right versive gaze. Okay, left or right versive gaze. Okay, both extremities merong generalized tonic and clonic movement. Kapag isang side lang yung gumagalaw, okay, then that is already focal, okay? It does not last more than 15 minutes, okay? And usually, after the seizure, medyo drowsy sila pero nagigising din yung mga yan. And it only occurs once in 24 hours, okay? So, hindi dapat siya uulit-ulit. Pag umulit-ulit siya, then that is already your complex or complicated febrile convulsions, okay? Pag na-fulfill niya, so more than 15 minutes, more than 1 in 24 hours, okay? Any of those. So, yung BFC, dapat all. Ang CFC, any, okay? So, more than 15 minutes, more than 1 in 24 hours, focal yung seizure niya. After the seizure, meron kang focal deficit, then that is CFC. And the difference is, ang CFC, you have to work it out, okay? You have to do your work up. Baka mamaya, may ibang problema yan. Okay? Status epilepticus, by definition, is 30 minutes of continuous seizure activity or multiple seizures without regaining consciousness. Okay? So, there's a high probability that it's a CNS infection kapag yung patient nyo goes under status epilepticus. Of course, there are a lot of other etiologies na pwede. Okay? Additional information, this is from the ILAE report, okay? Definition and classification of status epilepticus. We have an operational definition of your seizures. Pag sinabing operational definition, this is the time wherein you have to act and abolish the seizure. Try to abolish the seizure. Bakit? Okay? Because during this T1, operational dimension 1, okay, there's a high probability that the seizure will prolong and lead to status. And for T2, there's a high probability that the seizure may cause long-term sequelae or consequences. And what is those T1, T2? For tonic-clonic, the T1 is 5 minutes, meaning in 5 minutes, nagsisizure pa rin yung patient nyo, dapat nagbibigay na kayo ng gamot nyo. Okay? And for tonic-clonic, if that lasts for 30 minutes or more, there's a high probability na mayroon siyang long-term consequences. Okay? For focal seizure, it's 10 minutes and more than 60 minutes. And for absence, it's 10 to 15 minutes. Okay? So, please do remember those definitions. The definition of status epilepticus is again 30 minutes, but the operational definition will depend on the type of seizure. Okay, and you have two operational definitions, 1 and 2. Okay, and how do you approach your patients with seizure? You can use these guidelines. Although of course we have our local guidelines. PGH has one. Philippine Children's Medical Center, where I came from, also have their own guidelines. Okay, hindi naman masyadong nagkakalayo. Usually tailor fit lang yan kung ano yung available na gamot na very common. Okay, sa ibang bansa midazolam mas common ang readily available. In the Philippines mas maraming gumagamit ng diazepam, pero they belong to the same drug class. Okay, so you can look up this journal and let's briefly do a run through kung paano siyang ginagawa. Okay. We will focus here. Ito yung pinaka-important. For the first 5 minutes, that's your stabilization phase. Anong ginagawa ko pag may dumating na patient na in active seizure? Of course, you do your ABCs. Your airway, breathing, and circulation. Very important yan. Okay? You monitor the vital signs. Check when the seizure started. Okay? ECG monitoring if available. Check for the glucose. Okay? One of the most common causes of seizure is hypoglycemia. And then you do your IV access to collect your laboratory workup. Okay, electrolytes, hematology, toxicology for considering it. And if these are patients maintained on AEDs, anti-epileptic drugs, you check for appropriate levels. Okay, and for the first phase, the initial therapy phase, what do you give? This is 5 to 20 minutes. Our first line would be your benzodiazepines. Okay, so benzodiazepine is your first line of therapy. Okay, you can give midas, diaz, or lorazepam. So please remember that. Diazepam can be given IV or sa rectum. Midazolam can be given buccal, pwede sa bunganga. Okay, if none of the 3 options are available, you can use phenobarbital, rectal diazepam, intranasal, or buccal midazolam. After the initial treatment, if hindi pa rin nag-resolve yung seizure, okay, what's the next line? We usually use our barbiturates. Okay, so phenobarbital. Kaya lang for the past few years, nagkakaroon ng shortage ng phenobarbital. What we usually do or what we usually use would be your phenytoin. Okay? Kapag hindi pa rin gumana yung mga second line option, okay, ano yung binibigay natin? There's no clear evidence to guide the therapy, but locally, we use our general anesthetics. Okay? So, this is a brief overview. Okay? I don't think they will ask specifically kung ano talaga yung ginagawa or binibigay na gamot. Pero, my purpose here is to summarize to you kung ano yung progression ng medications natin. So, basically, it's benzodiazepine. Pag na-maximize mo na yung benzodiazepine, hindi pa rin tumitigil yung seizure. Okay? We give our barbiturates. Pag na-maximize mo na yung barbiturates, hindi pa rin tumitigil, we proceed to our general anesthesia. Okay? So, yan. So, choose one. Alright. Okay. So, yan. So, summary of those guidelines, nasabi natin yan, CABs, first and foremost, very important. Glucose, you check for the electrolytes. Which electrolytes may cause seizure? The arrangement of these electrolytes may cause seizure. That would be sodium, calcium, magnesium, and phosphorus. Toxicology screening, blood levels of drugs, hypoxia. If you're suspecting hypoxia as a cause of seizure, you can check your blood gas. And yan, benzodiazepines, barbiturates, and general anesthesia. If I'm not mistaken, this is our last case. So, sana guys, marami kayong natutunan for this short session in Pediatrics Genesis. I try to give as much as I can with the given time. And hopefully, maalala nyo yung mga tinuruan natin. Mga pinag-aralan natin. I don't expect you to remember everything in one sitting, so hopefully balik-balikan nyo itong mga lectures na to because again, this is like a crash course for the board exams for those who are taking the clerkship and internship. So these are very common cases that you will see during your rotation in pediatrics, and hopefully you will be able to diagnose them and at your level at least request for the diagnostic tests needed and management. Okay, so you have a 4-year-old male who was brought into the clinic due to coughing and wheezing, usually worse at night. So very important yan. So coughing and wheezing worse at night. Okay, in the morning the patient sneezes a lot with nasal congestion and clear discharge that goes away throughout the day. So mas malala po yung sipon-sipon niya saka pagbahing-bahing niya pag umaga pagkagigising. Okay, so this probably points to what case, diba? Allergic rhinitis yan, yung sentence na yan, diba? So na-discuss natin earlier in this session yung allergic rhinitis. Okay, so the symptoms have been occurring intermittently for the past year. Okay, recently he and his older brother had cough, colds, and mild fever for the past 2 weeks. So 2 weeks ago daw nagkaroon sila ng cough, colds, saka mild fever. Okay, he also had a history of hospitalization when he was an infant from an undercold infection na nagwi-wheeze din daw siya, sabi ng mother. However, his coughing and wheezing has progressively became worse, okay, with the mother noting difficulty of breathing. Kaya sila nag-consult sa ER. Heart rate is 105, tachypneic at 46, 37. There's polyphonic loud wheezing on bilateral lung fields, mostly on expiration. So expiratory wheezes, diba? Very common to in bronchial asthma. Okay? There's also occasional rhonchi, and in some cases may mga crackles pa nga, and there's a prolonged expiratory phase. What is most likely diagnosis? Okay? And of course, your question here would be, could this be asthma, or could this be other types of diseases which will present as wheezing as well, such as bronchiolitis, diba? So given everything that has been said in this case, probably this is bronchial asthma. Okay? So it's a chronic inflammatory condition of the airways. How I explain this to my patients is that yung airways po ng bata, mas sensitive siya to triggers, okay? At ang nangyayari, nag-i-inflame, namamaga siya. Pag namaga siya, sumisikip yung daluyan ng hangin, that is why there's wheezing, that is why there's difficulty of breathing and cough, okay? This inflammation results in episodic obstruction. So it's a chronic disease, on and off, nagkakaroon ng obstruction. There's airway hyperresponsiveness, okay? So sensitive, hypersensitivity, hyperresponsiveness of your airway to triggers, such as, ano ba yung mga triggers? Madami, di ba? Smoke, yung iba pagkain, yung iba physical activity, yung iba pag tumatawa sila na sobra-sobra, okay? There are two common types according to Nelson, so recurrent wheezing and chronic asthma. Okay? But in reality, mahirap i-distinguish yung clinical spectrum ng mga to. Okay? And your guidelines, your GINA guidelines will say that mild to moderate persistent asthma have around 40% chance of developing intermittent disease. Okay? So yung mga mild to moderate, there's a 40% chance of developing intermittent disease. Okay? So if they're to ask you, ano ba ang pathophysiology ng asthma? Okay? It is these top three. It's bronchoconstriction, airway hyperresponsiveness, bigla naging highway kalsada, and increased mucus production. So please do remember this, okay? So this is very important because this explains why you would have some patients with asthma who will have mucus production, who will have crackles, who will have productive cough. So hindi lahat ng asthma dry cough, although it's a more common pattern, but you can still also have asthma na productive yung cough niya, okay? Mind you, asthma is very difficult to diagnose in children, especially or specifically those who are less than 2 years of age, okay? For one simple reason that you cannot do spirometry to these patients in this age group, and another reason is that the presentation varies a lot, unlike in adults na medyo mas stereotypical yung presentation niya. Okay, so these are from me. Okay, of course they are based from the knowledge that I've learned in books, in residency, and in training. Okay, please do remember not all that wheezes is asthma, and not all asthma will wheeze. We were taught this during residency. Very important yan. Okay, hindi lahat ng pumipito ay asthma, bronchiolitis, viral respiratory tract infection. These are very common, specifically and especially for less than 2 years of age. Okay, but it doesn't mean it's asthma. Kasi we see a lot of patients, doc, asthma daw po. Bakit po? Inatake po siya nung ano siya, 1.5 years old. May lagnat, may ubo, nagwiwis, pumipito, sinabihan ng asthma. After that po ba may umulit po? Ay hindi, wala na po, doc. Mga 5 years siyang tuloy-tuloy, walang symptoms. Then probably that's not asthma. Okay, and not all asthma will wheeze. We have asthma na cough variant, so cough variant asthma, so predominantly cough lang siya pero wala siyang wheezing. Okay. So in 2 years old, yan, viral infection is a common cause of wheezing. But please also take note that it is also one of the most common trigger of asthma. Okay? So kaya mahirap siyang i-differentiate. Okay? So hindi mo alam kung asthma ba talaga yan because viral infections will cause wheezing, but at the same time, viral infections may trigger asthma in patients who are predisposed to developing asthma. Okay? So what are the common features that will tell you that probably this is asthma? Look for a family history of atopy or allergy. Okay? The symptoms are usually worse at night. And when we say at night sa libro, usually ang mga madaling araw. So anong clue dyan? Nagigising po ba sila? Okay? Nagigising po ba sila sa kalagitnaan ng tulog nila dahil sa pag-ubo, dahil nahihirapang huminga? Okay? It's exacerbated by triggers, very common ang physical activity and fatigue. Okay? Usually there's no fever in a patient with asthma exacerbation. Okay? But again, viruses can cause fever and viruses can trigger asthma. And usually there's a chronic and recurrent history. Okay? So, according to GINA 2019, okay, the diagnosis of asthma in young children with a history of wheezing is likely if it occurs with exercise, laughing, crying, or absent of apparent infection. There's a history of atopy in the first degree relatives, and there's clinical improvement during 2 to 3 months of controller treatment. So, pag nag-respond siya sa asthma controller medication, then there's a high probability that you're likely dealing with asthma. Okay? And here's a probability of asthma diagnosis from GINA again for children 5 years and younger. Okay? So, symptoms, okay, for less than 10 days during upper respiratory tract infection. So, nagkaroon siya ng urti pero hindi tumagal ng 10 days yung wheezing niya. Only 2 to 3 episodes per year, and then there's no symptoms in between, probably it's not asthma. Okay? Symptoms lasting more than 10 days. Okay? More than 3 episodes. Okay? Or severe episodes and nighttime worsening. Between the episodes, yung child nag-uubo-ubo pa rin siya. So very important to. Lagi kong tinatanong to. So for example, I have a child na nagkaroon siya ng wheezing episode ng June, and then he came to me at August, may wheezing episode siya ulit. Tinatanong ko, nung ginamot ko siya ng June, kamusta siya ng June and August? Pag sinabi ng mother doc, buong June and August after natin siyang gamutin, wala siyang ubo, wala siyang sipon, wala anything, then probably I might lean against asthma. Okay? So I might lean my diagnosis towards something else. Okay? Pero pag sinabi niya sa akin, doc, gumaling ng konti pero buong August, doc, parang every week may 1 day or 2 days na ubuhin siya, lalo na pag napapagod, ganyan, then probably it's more towards asthma. And of course, if you have allergic sensitization, atopic dermatitis, and other history of atopy, then probably you're dealing with asthma. If it's in between, then yan yung problematic kasi kailangan mo bantayan yung pasyente. So ito yung mga nasa gitna. Okay? There are different diagnoses of asthma based on GINA, okay, different years. This 2002 diagnosis is already outdated, but tinatanong pa rin to kung minsan, guys, because this is used for initial diagnosis. Because as you can see, yung classification natin sa mga mas recent na guidelines is usually controlled, uncontrolled, or partially controlled. Ang premise niyan is nagme-maintenance na sila. That's why you're assessing for the level of control. But for initial diagnosis, this is what we usually use. Is your GINA 2002 and you classify it as intermittent or as persistent, mild, moderate, severe. And here are the parameters that you measure. Okay, the daytime symptoms, nighttime symptoms, your peak expiratory flow rate, your variability, the difference, okay, between your peak flow in the morning and at night. Okay? And your forced expiratory volume, FEV1. Okay? So please do memorize this. Kailangan nyo lang talaga i-memorize nitty-gritty details. Okay? In 2019 guidelines, yan lang yan. Well-controlled, partly, or uncontrolled. Mas madali. And you ask for 4 questions. Ano yun? Daytime symptoms, nighttime awakening, the need for reliever, limitation of activity. Okay? If wala kang any of those, that is well-controlled. If you have 1 to 2, that is partly, 3 to 4, that is uncontrolled asthma. And this will guide your medication regimen. Okay? So the next few slides are the latest guidelines for asthma from GINA 2020. Okay? We will not go into the nitty-gritty details, guys, because as you can see, sobrang dami yan. So we have this one for adults and adolescents. Okay? Then we have this one for 6 to 11. Okay? And for 5 years or younger. Okay? So what do I want you to know regarding the treatment of asthma? Kung papansin niyo guys, okay, before we all know that you have your controller, which is usually your steroids and your LABA, and your reliever is your SABA, okay? But now, kung titignan nyo, the preferred reliever is a low-dose inhaled corticosteroid, okay? Corticosteroid formoterol combination, okay? So, our recent studies have shown that the use of SABA alone is not good. So, for the past 50 or so years, we thought that for intermittent asthma, for asthma na hindi magpo-fall into the persistent range, we thought na okay na tayo na susundutin mo lang siya ng SABA. But the studies have shown that there's an increased mortality, morbidity, and more difficult asthma control if we use SABA alone. That is why the newer studies now recommend to use your low-dose inhaled corticosteroids. Okay? So, look at this. For example, if you have a patient with less than twice a month symptoms, you can start at step 1. This is for adults and adolescents. As needed, low-dose ICS formoterol. Okay? Other options for controller is low-dose ICS taken whenever SABA is taken. Okay? So, hindi na tayo sumusundot-sundot. Usually, nagko-control na tayo. And for the reliever, it's as needed low-dose ICS formoterol. Okay? If the symptoms occur twice a month or more, but less than daily, then you can start here, low-dose ICS or as needed, low-dose ICS formoterol. So, it's a maintenance or pwedeng as needed. Ito, as needed. Okay? Other options would be your leukotriene receptor antagonist or low-dose ICS taken whenever SABA is taken. Okay? And so forth and so on. So, basically, guys, yun yung pinakamalaking change. We are no longer using SABA alone. It's ICS, inhaled corticosteroid formoterol combination, or if you're to use your SABA, you take a low-dose ICS with your SABA. Okay? So, please do remember that. Okay? So, this one is pretty much the same. Iba lang yung pagkaka-present. Okay? GINA 2021. 2021 na pala ito. I said 2020 kanina. 2021. Okay? So, this is adults and adolescents. Yan. For 6 to 11, okay, wala silang preferred controller. Okay? So, symptoms less than twice a month, low-dose ICS taken whenever SABA, or daily dose ICS ka na agad. Pwede ka na mag-daily dose ng low-dose inhaled corticosteroids. Okay? Reliever, sabi niyan, pwede pa rin SABA, pero again, yun nga, for asthma, okay, in 6 to 11 years old, ang recommendation pa rin dito pa rin tayo. Okay? Low-dose ICS whenever SABA is taken. So, if you're going to prescribe SABA for a patient with asthma, sabayan mo siya ng low-dose ICS. Okay? And this is for, for 5 to 11, 5 years or younger. Okay? So, yan. Okay? So, please do read these guidelines and management. I don't think they will ask in details exam kung ano yung specific na dose na ibibigay mo or kung low or high dose yan. Okay? But this is very useful when you're going to practice. Okay? Be it kung magpe-ped residency kayo or kung mag-manage kayo ng patients as a general practitioner. So you have to know how to use these medications for asthma. And it's really not that hard. Okay? Mukha lang siya magulo guys, pero pag tinignan nyo, madali lang yan. So again, very important. So let's go through this circle here that Gina is always telling us to do. So you have to always review your medications, the symptoms, the exacerbations, satisfaction of the patient. Your drug of choice will also depend on the availability of drugs in your area and kung ano yung preference ng patient. Okay? If you're having difficulty in controlling, you have to assess and reassess your patient. So check for alternative diagnosis. Okay? Check for your modifiable risk factors. Baka naman pala may laging naninigarilyo sa bahay, di ba? Or check for your comorbidities. Baka may allergic rhinitis ka na hindi mo kinokontrol. We all know that uncontrolled allergic rhinitis makes it difficult for us to control our asthmatic disease even more. So importante na you are controlling both of this disease entity. Baka naman mali yung paggamit ng inhaler, okay? So you have to assess all of these and then adjust your management. Treat your risk factors and comorbidities, non-pharmacological strategies, asthma medications, and very important, education. Okay? So for 5 years or younger, kung papansinin nyo, usually mga step 1 nila, saka kung where do you start, usually hindi siya as well defined as compared sa mga adults, di ba? Saka adolescents, di ba? And the reason for so is that wala pa masyadong data sa mga mas bata. Okay? So we usually start here. So daily low dose ICS kapag kailangan nyo mag-maintenance for less than 5 years old. Okay? Alternative is LATRA or intermittent short courses of ICS at onset of respiratory illness. Okay? If this does not work, ano yung step up natin? Double low dose ICS. Okay? Hindi tayo masyadong naglalatra. Okay? Hindi tayo masyadong hindi tayo naglalaba sa less than 5 years old. So kung papansinin niyo, di ba? Step 3 is daily low dose. Pag hindi mo pa rin makontrol sa double the low dose, okay? Refer to the specialist or add LATRA or increase ICS frequency. Okay? Or add intermittent ICS. As compared dito, papansinin niyo to ha, 6 to 11. Low dose ICS, okay? Na intermittent, taken whenever SABA is taken. Maintenance low dose is step 3 is low dose ICS LABA combination. So 6 to 11, nagbibigay ka na ng long-acting beta agonist. Pero dito, sa less than 5, hindi tayo naglalaba. Okay, so please do remember that. Okay? So for acute attacks, how do you manage it? The drug of choice is still your SABA and your steroids. Okay? Oral or IV steroids. Mind you, it's the same. If they ask you, ano yung mas matagal ang peak ng onset ng effect or onset of action, okay? It's actually the same. Oral or IV steroids. So you can give either. The only difference is, of course, if you have patient in distress, in respiratory distress, who cannot take in oral medication, then it's better to give it IV. Pero the onset of action and the peak of action of these medications is the same, IV or oral. Okay? If your beta agonist and your steroids, of course, your steroids guys usually mga 6 to 8 hours yan bago pa tumalab yan. Okay? So if hindi siya gumagana, you can add your anticholinergics, but please take note that it should never be used alone. You have to have your SABA. Okay? So that's your combination. So your SABA plus your ipratropium bromide. And methylxanthines can also be used for severe asthma, but please do remember it's not a first-line drug. Okay? Other drugs that you can use, magnesium sulfate, bronchodilator din siya. So we usually use that pag severe na yung asthma, pag hindi siya nag-respond sa SABA. Okay? So yeah, management between attacks, these are your maintenance medications, which was discussed more thoroughly kanina. Okay? And that is my last slide. We've discussed a lot of things about pediatrics. We've discussed anthropometrics, preventive pediatrics, vaccination, as well as common diseases in almost different subspecialties now you will commonly encounter. Okay, I hope you do learn a lot, guys, and I hope you do well in your clerkships and internship. And of course, we're doing this in preparation for your board exam. So I hope to see you in the Top Notch main season. We will be seeing more of each other sa Top Notch main season natin. Mas matagal yung mga lectures doon, mas maraming discussion, mas in-depth, mas detailed, mas yummy. Mas yummy na mas malaman. Okay, so maraming salamat, guys, and this is Dr. Rivera again. Have a good day.